try to get the EIDBI licensure study report in, but we had a great conversation and the time just went where it's at. So thank you for coming back. And then also, we got a bunch of testifiers. So I would ask testifiers, just because what happened last time, if you could keep your remarks to, 2 minutes. They're going to be for the record, and then we can set up some follow-up after that. There's, right now I have 5 folks that want to talk about this, but we are here, and then you're going to stay with us, Ms. Grom, and go into the obsolete rules report after that. And then there's going to be 2 bills. I'm looking at, we have Senator Fateh, medical assistance income limit for people with disabilities and people age 65 and over, the increased provisions. You got a couple people on that one. And then Senate File 476, the MA provisions. That is something we've always had a discussion there. I think Senator Aki's on that, Senator Abler, Senator Gruenhagen, you might be on that bill too. So with that, Ms. Grom.
Thank you, Mr. Chair and members. For the record, my name is Christy Grom, and I'm the Director of State Government Relations at the Department of Human Services. And I am here today to talk about Early Intensive Developmental and Behavioral Intervention, or EIDBI, and the licensure evaluation that DHS has been working on over the past couple of years. So as part of this presentation, I'm going to talk a little bit about what the legislative requirement was for this particular study, what EIDBI is, the process that we use for conducting the evaluation, as well as our recommendations, and an overview of the governor's budget recommendations as they relate to this topic. Let's see if I can work my slides. All right, so the enacting legislation for this particular study was proposed by Governor Walz, Lieutenant Governor Flanagan back in 2023 to the legislature, and we are grateful that you all authorized funding and for DHS to move on with that work. So we've been working over the past few years, working with community, working with experts, working with providers, people who use services to conduct this evaluation and make recommendations. The way we've done this study was really to partition it into 3 different parts. So we'll talk a little bit about each of those particular segments, and you can find more information about them in the study itself, which should be in your packets. But there were 3 parts, including pretty extensive community engagement. We did some national comparative analysis between Minnesota and other states. We looked at the EIDBI service itself and tried to distinguish some identifying characteristics and why it may not be a good candidate for licensure, and then made a lot of recommendations on health and safety investigations and so on, and we'll get more into the weeds on those. So taking a step back, what is EIDBI? EIDBI is a medical assistance service. It was authorized by the 2013 legislature and implemented in 2014 or 2015, thereabouts. And this is a service that provides services to children and young adults under the age of 21 who have autism or related conditions. And really on this slide, you can see the overarching guidelines of this particular services to educate and train parents and families, to support community life, making sure that children are able to be fully integrated in their families, in school, other activities, and ultimately to improve long-term outcomes. So early intervention is interventions in the name. Obviously, that's key. We want to make sure that children and young adults are getting services in those correct developmental windows so that they can have better outcomes. More specifically, just wanted to provide some examples to the committee of what the specific services might look like when we talk about EIDBI. So really, when it comes down to it, we're talking about therapies that support children and young adults to have better practical or functional communication, to enhance their interpersonal skills, to address complex behaviors. So last week we talked about individuals with complex behaviors. Oftentimes in this case we see intellectual developmental disabilities coupled with behavioral health conditions, leading to the need for more services like EIDBI. And these services are also helping children to self-regulate. They're improving cognitive functioning and supporting better safety skills. So this is a state plan service. It's a little bit different than the waiver services that we talk about in this committee, but it's a state plan under our EPSDT benefit. And as I mentioned earlier, it's a community-based service, so it can be provided in clinics, in schools, sometimes in facilities as well. And the last thing I want to say about EIDBI with this slide is just that it is an incredibly necessary service. We have growing numbers of autism, the prevalence and severity of autism across Minnesota and across the nation, as well as the disparities, is increasing. And so it's critical that we take a look at this service, we make sure that it has the appropriate oversight so that it can get to the people that really need it and people have access to the service. So this committee has heard a little bit about EIDBI modalities. So a person may receive treatment intervention according to one of these modalities that's in front of you. So we've got, about 6 or so of them. So applied behavior analysis is one of the main modalities that's used, as well as developmental individual difference, relationship-based, Early Start Denver model, play project, relationship development intervention, and early social interaction. So it really depends on what the individual's needs are, what the parent identifies as the needs in the treatment plan in terms of which one of these modalities is provided. And in Minnesota statute, the commissioner has flexibility to add more modalities as this is a pretty quickly evolving clinical area, and we want to make sure that we've got access to the cutting edge services. One thing to note here is that Minnesota is an outlier in terms of how many modalities we provide. Most states do not provide this many modalities. We've done some scanning. New Jersey and Oregon provide a couple of these, but overall, Minnesota is on the cutting edge of allowing more modalities than other states. So, quick overview of EIDBI provider types. I think it's helpful to see what these various provider types are to understand their specific and unique roles in the EIDBI service delivery. And also to share, you can see that while EIDBI is not a licensed service in DHS, under DHS, many of the individual providers that provide the service are licensed and are bound to professional licenses. So one of the services, the Comprehensive Multidisciplinary Evaluation, or otherwise known as a CMDE, must be provided by a physician, an advanced practice registered nurse, or a mental health professional. And this is the assessment that really determines if a person meets medical necessity to receive EIDBI services. Qualified supervising professionals, or QSPs, have similar criteria in terms of provider qualifications, so physicians, APRNs, developmental or behavioral pediatricians, or licensed mental health professionals. And we'll talk a little bit about it in the next slide, but this is the provider type that oversees all of the clinical services that are provided under EIDBI. And then the level 1 provider has 2,000 hours of clinical experience or training and the equivalent of a graduate level coursework. Level 2 and level 3 providers have a variety of kind of complicated provider requirements, but it's a combination of either a provider or a bachelor and an associate degree combined with various levels of clinical or experiential requirements. And one last thing to note on this slide is every EIDBI provider organization must have at least one advanced certification provider, which is usually the QSP or the level 1 provider. And so they are providing additional oversight of this service. So I mentioned clinical supervision and the QSPs in the previous slide, and just wanted to make sure that the committee understands that the QSP is really taking full professional responsibility to make sure that the individuals they're supervising under this service provide EIDBI services that are medically necessary, clinically appropriate, culturally responsive, and that they meet really the unique needs of each individual who's using the service. And then I won't read all of these, but really making sure that the individual worker is providing services that are competent, professional, done in an ethical manner, that they're keeping up with their ongoing educational requirements, and that they're meeting the fidelity of the service modalities. So we've got some oversight built into EIDBI at the professional individual provider level, but I think there's been, we've definitely identified a need for more oversight, which was the impetus of doing this evaluation. As I mentioned earlier, we've done this study in 3 phases. So the first phase was completed back in February of 2024, and there's a link in your packet so you can click to see what all of the information was in that phase. But really, this phase was The intention was to gather information, to summarize the existing standards related to the service, provider qualifications, health and safety, and really to inform community thinking and discussions related to potential decisions about oversight for EIDBI. So that was really the first foundational evaluation that we did that can be found on the DHS website, and you can click on the link here. The second phase was completed this past summer in August, and it spanned about 4 months of harvesting wisdom from the community. We used surveys, we used focus groups, really making sure that we understood from professionals, providers, as well as families and caregivers what was working, what isn't working. Are there key themes that we're identifying as we're having those focus group discussions and getting survey results? And what are their concrete suggestions to improve EIDBI? Wanted to note in this phase we did really intentional focus and outreach to Somali, Latine, and Native communities, really trying to make sure that we captured the specific and individual needs of those communities in this work. And then lastly, the third phase is what really encapsulates the report that we're talking about here today, and it's really about why we need licensure and why we think it would address some of the current challenges we're facing, and it's recommending both interim and long-term strategies. So the overarching recommendations, if you've had a chance to look at the report, great. If not, those recommendations start on page 31 of the report, and they're pretty extensive. Generally speaking, DHS recommends that we do license this service, and that while we're licensing it, that we're ensuring to not just enhance the oversight, but to make sure that we're balancing access to services. So it's an art, not a science, to do regulation. We've talked about in this committee over the years, are there too many regulations when it comes to substance use disorder? Are there not enough? And how do we get that right balance so that we have, that we aren't inhibiting access, but we've got appropriate oversights? And so that was really the resounding recommendation that we heard from committee, and that DHS really stands behind. So in the report, you'll see a variety of recommendations, first and foremost related to health and safety. We also have recommendations related to how DHS should investigate when there are violations of health and safety, what the administrative and clinical infrastructure should be for EIDBI programs, what kind of supervision standards we should put into statute. So how many hours per week should someone who's delivering this service get in oversight from their QSP? Should there be caseload limits, and what kind of training requirements and documentation requirements should be codified? I did want to lift up a few other things that were in the second report that we heard from community on. I think it's important to really make sure when we're talking about regulation that we're centering the experience of people. The decisions that we all collectively make here, the recommendations DHS is making, have the potential to really impact individual lives. And so we need to be cognizant of it and lift up some of the feedback and concerns that we've heard. So we definitely heard from the community that increased regulations could mean less access to services. We need to balance that. We've heard from the community that they would like customizable templates that reflect how services are delivered in different settings and culture. They want clarity on health and safety standards in terms of emergency restraints, medication administration, food hygiene, and other safety requirements. They also resoundingly said that they want more training. They want to have mandatory CPR. They want to have practices, more training on incident reporting and cultural responsivity. And then lastly, one of the things I wanted to highlight, because I think it's something we need to look into further, is there were comments that EIDBI providers were struggling to interact and get services in schools, and that there were some silos between special education services and EIDBI services. So maybe not a licensure or regulation issue, but just something that the community has mentioned that collectively we want to work with all of you to solve.
It's Dollar General audio.
So why is licensure needed? So licensure sets minimum standards, doesn't solve for everything, but it does provide a firmer foundation from which we can oversee basic health and safety. A few things to note that we've been seeing in terms of the EIDBI service. We've seen that the clinical supervision is being stretched really thin, in some cases leading to safety concerns. We've seen that some providers are being listed with multiple centers simultaneously. So we've seen that some licensed professionals are affiliated with maybe 15, 20 centers, which would mean that they are in charge of supervising more staff and children than would be clinically appropriate to do so. We've seen that providers have out-of-state addresses, and we're wondering, if they're doing the appropriate on-site supervision if they're out of state. And we've also seen a growing number of providers enrolling, and so we just don't have the capacity at the department to keep up with that many providers and the oversight, even the current oversight mechanisms in place. So this chart shows individual EIDBI providers that enroll. So providers enroll both as individuals and as an agency, and so this is the individual providers, and you can see it's expanding exponentially since 2022 or so, which in some ways is good. I remember back in the day, when this service first came online, and Senator Abler would ask, why aren't there more EIDBI providers? Is this working? And not to call you out, Senator Abler, but I know you've been a champion of this service, and it was true. We were trying to get more providers at that time. We wanted to have more access to this service. And so, as expected with any new program, we see that the number of children receiving services has really grown. The numbers are pretty astounding. So in 2023, I think we had over 4,200 children in services, compared to about 3,322. So about a 30% growth in the number of participants. And then we saw provider agencies quadruple from 2020 to 2024. So you can see there's just a ton of growth in this sector. And the last thing I would say about this slide is the rapid increase in growth has led to some EIDBI provider agencies and individuals indicating there's some operational inconsistencies, and we've identified those at the state as well. So some providers who participated in our study said they need more direction from DHS, they aren't sure about what the policies are, and providers have reported multiple challenges in terms of the enrollment process and really being fully prepared to deliver the service once they come online. So the 2025 DHS licensing proposal is actually a provisional licensure recommendation in the governor's budget. And you can look at the change page. If you don't have that information, I'm happy to send it to the committee, but you can look for more information about this proposal in the change page, and hopefully the legislative language will be introduced in the next couple of weeks. But really the first immediate action that we need to do, in our opinion, is to address the program integrity and well-being of people through the provisional license structure. And so this proposal initiates that. It would create a provisional licensure in Chapter 245A. This proposal would also allow DHS to identify controlling individuals and to disqualify ineligible individuals. Right now, without a licensure oversight, we don't have that capability. It would allow DHS to investigate maltreatment and suspend or revoke license when we're seeing that maltreatment, and also to ensure that background studies are completed and that all the provider qualifications are met prior to providing the service. So you'll see in the change page as well, we do need some resources to support this work. So after developing a provisional license to address the immediate needs, we will need to continue to work with community, parents, service recipients, providers, and others to fully develop and revise the final licensing standards. And so this slide just shows you some of the activities that we'll be doing. This is a pretty high level, simple overview, but it's very intense and very difficult work that will take some time and will take a lot of person power at the department. In terms of timeline, we would hope that the legislature would agree with us on some of these recommendations and that we could pass the provisional licensure this session. If that is the case, in 2025, we would begin designing the licensure and making sure that people are applying for the provisional licensure. In 2027, and between then and 2027, we'd be doing all of that work with community, continuing to define the final licensure standards. We would be coming back to the legislature, hopefully, and making a recommendation about what that final licensure should look like. If it passes in that session, then we would think that the earliest start date for the full licensure would be July of 2028. So I would say that's an ambitious timeline, but one that we're committed to. We really agree and understand with community about some of the issues that we want to address in this service. Lastly, just wanted to share, there's a few other items in the proposal related to program integrity, but aren't specific to the provisional licensure. So one thing to know is that CMS generally categorizes providers into limited risk or low risk, moderate risk, and high risk based on their potential for issues in the service line. High-risk providers have more scrutiny. They have a revalidation process that occurs every 3 years instead of every 5 years, like moderate risk, and they're just subject to different documentation requirements. So DHS is proposing to move EIDBI providers to the high-risk category to make sure that we can enhance their revalidation schedules and just have more stringent requirements for that particular service type. This proposal also makes sure that DHS is the lead investigative agency for maltreatment. So right now, the lead investigative agency would be local law enforcement. So when there are significant safety concerns like we saw last spring, for example, DHS has been unable to intervene, and we've instead had to defer to law enforcement. Lastly, it's not on this slide, but I did want to mention there's been some legislative interest in contracted employees and whether or not the statute is clear enough that certain employees cannot be contracted, and there is a clarification in our proposal to ensure that we clarify that that workers need to be the employee of an agency or employed by an agency. So that's the quick overview I had for the committee. Hopefully my time was not too long. Happy to answer questions or hear from the testifiers.
Your time is great. Senator Abler, then Senator Rasmussen, and then Senator May-Quade, and then Senator Gruenhagen. Might as well add Utke into that too. Why not?
Noticing the, so Mr. Chair, noticing the flurry of inquirers here, maybe you want to get, just to suggest, maybe you want to fly through the testifiers first, and we're going to discuss this a lot. So, and just if I could ask the testifiers, if they could comment on what modality, there's like 6 or 7 modalities, if they could just make us aware of what line they were in, happy or sad about it. Thank you, Mr. Chair.
I agree. Members, you all good with that? Can we hold off and let's get through folks and hear about, the lived experience, because I know there's lots of topic on there. So, Ms. Crown, thank you. So we're going to go right to the Zoom land. Anissa Hagi Mohammed and Najma Siad, you both are on there. Let's start with Anissa Mohammed. Are you able to?
Yes, I'm here. Senator Hoffman, give me 1 second.
1,000.
Okay.
You're good, Anissa.
Najma, would you like to go first?
Yeah, go ahead.
Setting up.
Oh, yes. I don't mind. Hi, Senator Hoffman.
Hello, Najma.
I would just like to, my testimony is deeply informed by my personal experience and my commitment to social justice and my belief in the need for equitable, effective systems to support families like mine. I am the mother of a bright and resilient 4-year-old child with autism, and I come from an African immigrant background, raising my family in Dakota County. My son currently receives ABA, or Applied Behavioral Therapy, and it has been a transformative tool for my family and helping my son overcome challenges. And through ABA, he has developed essential communication skills, self-regulation strategies, and great independence, all of which have improved his quality of life and strengthened our family dynamic. So it's a bit concerning when singular narratives dominate conversations about ABA, often disregarding the diversity of experiences within the autistic community. As a Black mother raising a Black autistic child, ABA is a universally, sorry, I can't speak, I'm a little emotional. But the discussion around ABA must reflect the diverse realities of families across Minnesota, including research that comes from DHS, and widening the pool of who's involved in that and what families are involved in that and what organizations are reached out to. Yeah, I do have some more things to add, but being cognizant of time. Anissa, would you like to go?
So thank you, Ms. Siad. I think also members in your packet is some other information too, but, thank you for your
Yeah.
lived experience in helping us understand what is work. And Senator, well, he'll be right back, but he wanted to know the modality that's there, so thank you for doing that. So Anissa Hagi Mohammed, welcome to the committee.
Thank you, Senator Hoffman and the Human Services Committee for giving us the opportunity to talk about our lived experiences. My name is Anissa Haji Mohammed. I am a parent of 3 autistic children on different sides of the spectrum, and they have been benefiting tremendously from EIDBI services. I'm not just a parent, I'm also a board chair for a community organization called Mangar Voices. And our work is amazing, and it's been national. We've been in a PBS documentary talking about the rise of autism in the Somali community, particularly, where it's 1 in 16 children are diagnosed as autistic, and those numbers would alarm anyone. And that kind of ties into our discussion here about EIDBI. There's a lot of discussions about EIDBI and how it impacts the state and how it's impacting families, but we think that a crucial seat at the table is missing for community organizations. And so there was talk about engaging the community and talking to the Somali community, but we haven't seen that engagement in the numbers that we have, been hoping for. And the community organizations that currently exist, like Mangar Voices and others, have not been contacted and have not been used as a resource, as an asset to be intermediaries and to be liaisons for the communities that we serve. No one has the impact that we do. No one knows our community like we do. And so some of the points that I wanted to raise is that EIDBI is beneficial, and I think licensing is an interesting topic, and I think it should be done very carefully so that it does not harm communities of color like ours. These measures should be educational. They should be rehabilitative. They should be pouring into our community, and they should not be punitive. For me as a parent, I'm just curious as to why DHS was so slow to move for years and years when so many parents were complaining about larger institutions and how there was maltreatment and neglect and abuse of children. And now that there's minority providers, and we're so happy about that, now there seems to be more punitive measures being discussed. And so that concerns us, and I think that we are asking that we as organizations are invested in to be middle people, to be intermediaries between our communities, and to make sure that we come to a resolution that benefits all parties. And I think this licensing is something that needs more time. It needs more community conversations, and it needs more families at the table so that we're not rushing to make a decision that's not equitable. Equity is that we are here and we are deciding the fate of our children and our families. Thank you.
Thank you. Thank you very much for your testimony. You guys, you can stay on the Zoom if you two want and hear what everybody else is saying. And if there are questions afterwards, maybe if somebody from the committee has it, that'd be great. If not, Abdi Karim, Hara, Abdulkadir Hassan, and Miriam, Miss Osman, you're here too. I think there's room for 2 if 2 want to come up, and then, all 3 of you come up. Christy, you want to, or let's just get the pages. Can we add another chair out there so we can get the 3 folks so we can ample time? Thanks, Christy. Miss Grom. Abdi Karim Harai is the advocate for Mangar Voices.
Yes.
There you are. Abdul Qadir Hassan, you're the executive director of the Somali Parents Autism Network. Thank you for being here. And then Mariam Osman, of course, a wonderful advocate. So There you go. If you could make room. Who's going to go first? Abdi Karim, you want to go first? Thank you.
Sure.
All right, for the record, state your name. And also what Senator Abler, if you're talking about kind of modalities and stuff that you're seeing, that would be great as well.
Hi, my name is Abdi Karim Hura. I'm a board chair of Mangar Voices. You've seen a couple of my friends that was testifying on Zoom a minute ago. Distinguished ladies and gentlemen of the Senate, my name is, like I said, Abdi Karim Hura. I'm a father of a 14-year-old autistic kid. I'm not only a community advocate, but I'm a father. Before we had the EIDBIs of the minorities, there was only a few big providers like St. David, Fraser. Our kids were in a long waiting list forever. We never had a chance. Our kids never get a chance, even though our kids were in a waiting list. Well, I'm one of the people that advocate to open up for our communities and other communities to open up their own EIDBI providers. And now that we're open and our kids are getting services, we're hearing so many different issues from the DHS and all this stuff that they're trying to make the license so difficult because of, it feels like to me, every time things reach out to the minority community, that's when people come up, or like the DHS comes up with all these rules and regulations that were never been there before. EIDBI services is critical to my son's progress. He had developed skills that allow him to communicate more effectively, manage transition, and function with more adequacy. Without these services, he would not be where he is today. However, I'm deeply concerned about the inadequate and how EIDBI's providers, particularly minority-owned providers, are being treated under the new license requirements. This is really deep to me because I've been from the get-go when we were only have to be on a waiting list for St. David and Fraser and complain about the DHS every day and nothing happened. But now that we open up services that can help our children, here comes the DHS willing to shut down everybody. Even if St. David makes a mistake, we have to pay the penalty. For years, Somalis and immigrant families have struggled to access appropriate autism services. Large institutions fail us time and time again, and our children suffer because of it. When cultural components profile finally emerge, they change everything they understood, that they understood our children, respect our language and tradition, and made service accessible to our families who had been shut out of the system for too long. Now these same providers are facing relentless scrutiny while large, predominantly white-owned organizations continue to receive DHS resources, private meetings, and behind-the-scenes support licensing. While important, should not be used to disappropriately burden the very providers who are failing gaps in the system. If we lose this, our children will be left without the care they need, and we will return to a long wait list, unmet needs, and increasingly struggle at home, in a school, and the community. This is not just about autism services, it's a social justice issue. I urge you to ensure that all providers, regardless of background, receive equal treatment, equal resource, and equal opportunity to serve our children, equal opportunity from the DHS. On that, I thank you very much for listening to me. Like I said, this is really deep to me. I experience from both ends, and I hope you guys do
Thank you.
listen to what I said and do something about it.
Thank you, Abdi Karim. Thank you. Abdul Qadir, Hassan, you want to go next? And you have your prepared.
Yeah, thank you.
Did you also email your statements? If you did, that would be great
Yeah,
as
I
well.
will email to you.
All right, thank you.
Yeah, thank you very much. My name is Abdul Qadir Hassan. I'm the father of son, now is 21 years of age, who was diagnosed with autism at the age of 3 in 2006. At that time, early intervention services, specifically applied behavior analysis treatment, were not really accessible for low-income families with children who have special needs. For that reason, my son missed the early intervention services that would help him to be an educator and taxpayer citizen. However, I was among the pioneers, parents, advocates who took a stand to ensure that our children receive the necessary services, but I faced a lot of obstacles, poor services, and lack of progress. When I realized that the school in Minneapolis was not providing the services, including my child's individualized education plan, and I had not seen any progress for 2 years, I filed a special education complaint with the Minnesota Department of Education. Minnesota Department of Education started to investigate my son's case and found out that the school violated special education law and shared with me that MDE will develop an action plan to fix the problems, which might include staff training, additional programming, or other make-up services. Discrimination and denial. Minnesota Autism Center was the first center that provided applied behavior analysis program through medical assistant insurance in the Twin Cities area in 2008. I applied for this program for money several times. My son was not accepted. And my son right now is still on the MAC waiting list. In late 2011, I went to Holland Center in Manitoba to enroll my son in their program. That center provides different services that are beneficial for children with autism, including ABA, occupation, speech language, biomedical intervention with hypoparic oxygen treatment. Unfortunately, I was informed that my son's lack of private insurance coverage would prevent him from accessing these essential services. However, the staff suggested that I advocate for legislative change to allow Holland Center to bill all services through MA insurance. Through collective advocacy efforts, a bill was passed to the extent MA coverage for all medical necessary services, but after 2 months, my son was dismissed from the program, and I have started again at square one. My son went back to 287 district public schools. In 2013, we continued our advocacy efforts, which culminated in the passage of law by the Minnesota legislature to establish an early intensive developmental and behavior intervention EIDBI benefit for children up to the age of 18 with autism spectrum disorder. Subsequent amendments have since expanded eligibility to include individuals under the age of 21 with autism and related conditions. Early intensive behavior intervention, EIDBI, also referred as comprehensive EIDBI, is frequently recommended for children under 5 years of age. This approach entails an intensive and individualized curriculum designed to teach communication, social interaction, as well as functional and adaptive skills. The long-term benefits of APA therapy services as well documented as an evidence-based intervention that has demonstrated significant positive outcome for individuals with autism spectrum disorder. And all other modalities have shown great outcome, such as developmental individual difference relationship-based model, call it dear floor time or picture exchange communication system, and etc. As a parent and advocate, I strongly support the EIDBI program that should stay forever, no change. This program gave parents many choices, include culturally appropriate centers that provide very good quality service. Also, I support that DHS must implement more rigorous monitoring to guarantee that children are receiving an education, families are aware of their rights and obligations, and that their program is evident. Thank you.
Thank you, Abdul. Thank you so much for your presentation. Next, members, we go to Mariam Osman. You want to slide over there, Abdul and get her some room. Ms. Osman, welcome back to our committee.
Hello, everybody. Hoffman, Senator Hoffman, and everybody. Yeah, I'm Mariam Egal, and I have been in Minnesota for the last 12 years. Before that, I was in Georgia and Washington, D.C. for a minute. What brought me here to this tundra is autism. I have 3 individuals in my immediate family, a 30-year-old, which has still severe autism, myself, who has a 27-year-old that has not been diagnosed because he doesn't want to do it. And I didn't believe early that he had any disability because I'm smart. My son cannot have disability. We are a family of educators, people who are educated, and our children cannot have learning disabilities. Denial. So what brought me to Minnesota was autism, as I said, and I have training in microbial pathogenesis and also in later years, public health, focusing on international health. So when I came here, my focus was to come to my target population, which are Somalis that have the highest prevalence of autism, 1 in 16. That's beyond, how would I say, an epidemic. So when I came here, I immediately hit the ground running. And my first thing was to defend EIDBI, the benefit, the treatment for the non-halves, where the halves with private insurance got services, therapeutic services, and whatever they wanted, as they wanted. The non-halves were not considered, they were under the bus. So the early intensive developmental and behavioral benefit brought them out of the table and gave them the rights, the human rights that they need, treatment for people who are severely sick. Autism is not a joke. It's a 24/7. So what I'm saying is about the licensure, what I'm recommending is that that licensure has to be very culturally inclusive. It has to consider people that do not speak the language, that do not have the culture, that do not have the means. That has to be considered. And if that's not included, nothing about us without us. Thank you.
Ms. Osman, it's always good to have you. Remind us nothing about us without us. Thank you for being here. I love that. Thank you.
That's how it all started.
Anissa Haji Mohammed, you had your hand raised. You want to add something, and then we're going to go to members. So, folks, Anissa?
Oh, yes.
Yeah.
Yes, Senator Hoffman, you asked about what modality we use as parents, and I don't think we, in our passionate testimonies, we forgot to answer that part.
Yeah.
I'm just going to turn my camera on. Give me 1 second. Sorry about that. I don't know how you do this every single day. It's very, it's a lot. But you mentioned the modality, and I think something I'll mention is that ABA is, of course, the most research-backed modality to help children who have autism develop skills and basically cope with a world that was not created for them. And my children are all benefiting from ABA therapy. And there was a testimony previously where someone from an organization here in Minnesota, quite a large organization, which for me was really troubling, that asked for the elimination of ABA therapy. I think that's very dangerous. And I think it's also speaks to a lot of privilege that people have in that they don't consider that other people are not living their realities. I have 3 Black children, as Najma said, and my Black children need to learn how to cope with this world. They need to learn regulations, strategies that keep them safe. when they stim outside, it's seen as a threat. Whereas a white child, they are coddled and they are comforted and they are taken care of. And my child, especially my 8-year-old boy, is going to be seen as a threat. And so I say this because I don't want someone talking for me as a parent, and I don't want someone talking for my community. And to eliminate a modality that is working, that is research-backed, that is something that we have been all praying and hoping for. And I think also that we explore other modalities is something that should not be, out of the question as well. Play therapy and other therapies should also be explored. I just wanted to say that quick note about ABA that when I heard that testimony, it really troubled my soul, thinking that a white woman was speaking for me as a Black immigrant, mother of 3 Black children, and demanding that something that is working for me and my family be completely eliminated. And this is coming from ARC, one of the biggest organizations. So I just wanted to say that for the record. Thank you.
Thank you. It's Public Law 94-142 talks about the unique and individualized needs of the child and disability and how it affects their education, right? I mean, it's a simple, grounded conversation, and to get an all or some. 2001 to 2004, I remember Dr. Greenspan getting in front of us when we were studying the autism, and 90% of the money then at the time federally was done in adult services, and Dr. Greenspan had said, because he does the ICI treatment, and I remember telling the folks, just it was interesting to see how there was at the time trenched in ICI. I think it was called ICI versus ABA. There's 2 different doctors who had their thing, and now it's wait a minute, let's blend that together. So to hear that comment, it's just kind of troubling, because I thought people would look beyond and say really what the unique and individualized needs are on that. So thank you. I know Najma Siad, you wanted to add in about modality for a couple of minutes, and then we got to go. Senator Abler, back to you after Ms. Siad is done, and it's all yours. So thank you.
Yes. I just wanted to add that the discussion around ABA must reflect the diverse realities of families across Minnesota, instead of speaking about abolishing it or shutting different autism centers. We should focus on improving the system that ensures it meets the needs of the families. Of course, ABA or certain centers are not without flaws, but its potential to empower families and improve outcomes is immense. Efforts should be directed towards refining its standards and enhancing cultural responsiveness and expanding accessibility. And DHS plays a vital role in this process. Licensing and oversight should aim to strengthen autism centers, not create barriers that disproportionately harm marginalized communities. And shutting down centers or imposing punitive restrictions will only further limit access for families such as mine, Anissa's, Abdikarim's, Miriam's, and Abdaziz, who rely on these services. And I just wanted to add that point. Thank you. Thank you for your time, everyone.
Senator Abler.
Well, thank you. And Mr. Chair, I always appreciate a reference to any public law that we can hear about. Historically, anyway, just not to be facetious. This is a big deal. I want to thank all the testifiers, I think the department for looking into it. I'm glad we could pass something in 2013. I was personally disappointed how long it took to get off the ground. I don't remember how many possible clients there could have been. It was like 30,000 or something, and we were barely hitting 1,000 a year. And frankly, the increased numbers of clients, students, whatever you want to call them, is great news to me. And so I think, the department and I share that. I'm just going to be brief here. I hope that I can be part of the people that work on this. It's really important. And so sometimes when you get a new program set up, this has like been, 12 years ago, it's like just too long to ramp up, and then it ramps up. And then suddenly, because of, not to impugn the department, they only have so many human beings that work there. But I think that the people who are concerned about this need to understand the term operational inconsistencies as a term that should frighten anybody. And so something else I want to point out from the report here, I read the report, it's really interesting. But for some reason, the cost per person in 2018 was like $13,000. And the cost a mere 5 years later is $45,000 per person. And I've been involved with some of the providers actually for a long time, back when I was under CFSS, and that's not how many people are going. For some reason, we're almost tripling the cost or more than that. That doesn't seem like a reasonable thing to me, and I don't know what's behind that. And for my money, I think whatever concentration of Minnesotans needs it, that's important, particularly Somalis and others that have a higher incidence. But as I look at this, I'm interested in, like, what the heck is driving that growth? Because if the growth is too high, we're depriving other people the chance to get it. You've noticed there's a budget challenge coming, and ironically, the governor in his chats singled this out as one of the reasons for it. I think the reasons were we wasted a lot of money on stuff I would never have bought. But this is something we cannot scrimp on to make sure every child in Minnesota needs a chance to have access to this. So I'm going to be looking at that. I'm also interested in just chatting with people in the different modalities. There's some modalities that are very well researched and that people agree, and there are some modalities that I'm just going to be blunt and quote my commissioner, it's her last day, that are fuzzy. She didn't talk about the techniques being fuzzy, but some of these are not well documented to be amazingly effective. And in the testimony, there were clients there that were being looked at while the worker would be on their phone. That's not exactly what I consider to be a well-rounded program, and I don't know what they're charging for that. So I'm also concerned about this out-of-state business. QSPs from Texas and Georgia, I don't know how that works, and I think if there's a red flag, that would be the reddest of red flags. And it's nothing to do with anybody's ethnicity or anything. It just has to work. And we want to make sure that all the programs that we serve in this committee, which are many, that there's enough services to go around for the people who truly have great need of that. And so, Mr. Chair, I could go on a lot longer, but I'm not going to. There's one thing else I wanted to mention that I think I forgot. But I think that, and also I want to make sure, as we go forward with licensure, there's, the ratios of how many QSPs you have, to how many workers under CFSS, there was quite a strict ratio that a lot of the ABA providers had to maintain. Is there no ratio anymore? Don't answer me now, I'm just gonna be working on that. And so there are some providers that are totally squared away. They've got, BCBAs, they got psychologists, they got QSPs coming out of their ears that are actually highly qualified. We don't want to make it more difficult for them to stay in business. We do want anybody who can do a good job of this to be able to get into the business, but if you have a lower credential and a newer approach, I do think we need to just keep a closer eye on some of those to make sure that everybody gets what they need. So, Mr. Chair, I'll just leave it at that. My door is open to people interested in this. I'm going to be working on a few things this year, and this is maybe one of those things. So, thank you, Mr. Chair.
It's a lifelong. I mean, I go back in the same conversations that you're having. This is like evolved, and to see that number. So I'd like to thank you for coming forward on that, Senator Abler. It's the next person, Senator Rasmussen.
Thank you, Mr. Chair. And I had a question for Ms. Grom. When we talk about EIDBI providers being unlicensed and the department's inability to kind of stop bad actors, is there anything in state statute that prevents you from stopping payments or having DHS stop payments to a provider that you're maybe concerned with or suspicious is providing the services as required?
Ms. Grom.
Mr. Chair, Senator Rasmussen, thank you for the question. We do have the ability to stop payments under certain circumstances, but there are some situations where we've identified in the governor's budget recommendations where we would like enhanced authority to stop payment on services. So I can get you the numbers on how many stop payments we've had in EIDBI in particular, but under the governor's budget recommendations, we do have some enhancements to give us more flexibility in certain situations to stop payment.
You would like, Senator, as more global authority on that, right? Because it goes back to some of the other things that you brought up a week ago, right? I mean, does that make sense to you? Yeah, Senator Rasmussen.
Thank you, Mr. Chair, and thank you, Ms. Grom. And I guess, when we're talking about providers that should qualify and be able to access this funding versus those that don't, is there anything, I guess my question is, why would you need a license to be able to say, this provider isn't qualified, we're not going to send payment? Is there anything that would prevent you from doing that today?
Ms. Grom.
Mr. Chair, Senator Rasmussen, you are correct that we do have authority today in law to stop payments, but providing, authorizing licensure requirements or provider standards isn't just about detecting and addressing fraud. It's also about improving quality of services. A lot of our licensing stops are, when we go and we meet with providers, it's really about education. And so it might be called a violation, but it's helping providers to understand what's safe, what leads to better outcomes. So certainly we have some authority there, but I think the licensure adds to that authority that we currently have.
Senator Rasmussen.
Thank you, Mr. Chair, and thank you, Ms. Grom. I appreciate that. And just one final question. As a part of this report, was there any work done looking at what other states have done in this space? Do you know how many states license providers like this versus have them unlicensed, or if there's any other alternative models like a certification or anything else that has been used?
Mr. Chair and Senator Rasmussen, yes, we did do a scan of other states. I believe we found about 38 other states have licensure structures for services like EIDBI. And then we've also noted that other states have licensed other services that Minnesota may not, like children's therapeutic services and supports, which is similar services being provided to similar populations. In Minnesota, that's currently a certified service, moving to licensure at some point in the near future. So we've done a scan, we've taken a look at some of those models. I don't have the details on the specific oversight models, but as we work with community and continue to develop final licensing standards, I think we'll be looking at those more in depth.
Thank you, Ms. Grom. Senator Rasmussen. Going to Senator May Quaid.
Thank you, Mr. Chair. And as per usual, I'm going to start with basic questions so I understand the program, if that's okay. Yeah. Okay. Going back to slide number 5, and you don't have to necessarily put it up, you said that there's 5 types of EIDBI providers. And I think there's about 4,500 providers total in the state or close to that. Are multiple kinds of providers housed in one type of center, or would you have like the Aaron May Quaid Autism Center and I am a level 1 provider, and then you would have the Jordan Rasmussen Autism Center and they're a level 3 provider? How does that work?
Ms. Grom.
Mr. Chair, Senator May Quaid, yes, there are various types of providers under each provider agency, and they all have unique roles in that space.
Senator McQuaid.
Thank you. So of these 4,500 providers, like they're one kind, like each one of them is one kind, or each one of them has multiple kinds of providers in it?
Ms. Grom.
Mr. Chair, Senator May Quaid, I suppose someone who's a qualified supervising professional or a CMDE provider would be highly qualified to provide a level 3 type of service, but probably from a workforce perspective, they just in practice would be my best guess of that, but I can get back to you with more information. So generally speaking, it's my understanding that the provider type just provides that one service.
Senator May Quaid.
Do you get it? I don't know if I get it. I'm so sorry. Because I'm looking at these like 5 kinds of EIDBI providers. And I guess what I'm wondering is when a parent goes, like they say, like my child goes to this XYZ center in Woodbury, is it one of these 5, is the place that they're going one of these 5 types of providers? Or are they receiving services from a person that is this level of qualified in here at the center, and there are multiple kinds of people at that one center.
Ms.
Yeah,
Crum.
multiple in one center.
Hold on, Ms. Osmond. It's okay. It's just, if you know the answer to that, then absolutely. Then I'll say, Ms. Osmond, you may go ahead.
I'm sorry.
Don't ever be
I'm a
sorry.
rookie.
You're good. I'm glad you're here. Ms. Osmond, you want to answer that question?
Yeah.
Go for it.
In each center, they have all those providers.
Thank you.
The QSP, the CMDE, the level 1, 2, 3, they are all there.
Thank you.
That's great.
Yes, that's super helpful.
Ms. Senator.
Thank you, Mr. Chair. And so do you have the numbers of, like, how many CMDEs, how many QSPs, how many level 1, how many, do you have those numbers?
Ms. Crum.
Mr. Chair, Senator McQuaid, we could get those for you. I assume when they enroll as a specific provider type, so we can get that to you.
Senator.
Mr. Chair, thank you. I would really love to know that. I think, I did read the report, and I don't think I saw that in there. My second question, seventh question, let's be honest, is I see the statute that we passed in 2023, and it was an environmental scan of licensure requirements for Medicaid autism programs in other states, and that we were to evaluate services for Medicaid. Are there, I guess, private health insurance, EIDBI providers that we didn't scan? And are those providers licensed or not, or are they the same as the ones that we're seeing here?
Ms. Crum.
Mr. Chair, Senator McQuaid, it's my understanding that commercial payers do sometimes authorize EIDBI services, but EIDBI that we're talking about today is specific to medical assistance, and I believe it's also covered under
Minnesota Care?
I believe it is. I'd have to double check the statute, but yes.
It sounds like you have an interest in this going regarding how things are changing in the policy-wise. So, yeah, I think that's all discovery on what's to do, what should we be doing the right thing, and
Yeah.
I think we're all on that same page. So, thank you. You want to follow up?
Yeah, thank you, Mr. Chair.
Yep.
So right now, when folks bill for services, that comes to DHS, and then is there a federal component of this, of the money?
Ms. Crum.
Mr. Chair, Senator McQuaid, yes, this is a medical assistance benefit, so there is a federal match on the services, and it's the service requirements are defined in our state plan agreement with CMS.
Senator.
Thank you, Mr. Chair. Have we had any interruptions in this federal match money coming in through CMS for these types of services?
Ms. Crum.
Mr. Chair, Senator McQuaid, as of today or as of this morning, when we connected with our team, we have not had any service disruptions for EIDBI or Medicaid. We are still assessing the situation to understand what potential federal changes could, how they would impact people, but we certainly know that Medicaid is a vital service, particularly for children and young adults, where I think it's over 40% of children in the state are covered by medical assistance. I don't have the specific numbers on the percentage of children under this benefit, but certainly we're concerned about potential implications in the future and are monitoring those.
Thank you. Senator.
Thank you,
Oh,
Mr.
keep
Chair.
going. It's all good.
Thank you. I think one thing I would make the formal request to the department is that if and when there are any payment interruptions, would you let the committee know immediately? Because as we have this detailed conversation about licensure, it would be, if all of a sudden this goes away, it would be a really important update to know while we're, fixing our garbage disposal, our house is burning down. I had one more question, Mr. Chair.
No, I think it's Senator Abler looked over, did you have a follow-up to that, Senator Abler? Because I got Gruenhagen and Fateh, but no, a follow-up with Senator, because I just saw you looked over.
Because I think we all want to know, people are nervous and we don't know what is, and you live on the front lines of that. So whatever you can tell us about what doesn't get paid, if one penny doesn't get to us that you're counting on, we want to know that. Thank you. Just to pile on to my seatmate here.
And would you, members, you want to have her come back after all this? It sounds like there's going to be some follow-ups and to that. So McQuaid, Senator McQuaid.
Thank you, Mr. Chair. And I appreciated the report, and I really appreciate the parents both coming in to testify and also for coming in online. I think, one thing that is coming up is it has certainly been used over the course of history, licensure to push people of color out of certain industries. And so we have the opportunity to not do that. And I wonder if one of the ways we can figure out how to best get our arms around this is to start with with all of the folks we have now, if they're providers, what would we need to implement to, what would we need to have in place to say you're licensed? Like if the assumption is everyone we have now is licensed, absent any, glaring things, what would that look like? And then kind of work it backwards, right? If folks are really seeing benefit from the services that they're getting, what would it look like to start with what we have now and say, this is what these things are what licensure is, and then work our way there. And then the last thing I'll say too is, I think we generally as a public have started saying like waste, fraud, and abuse, just those three in a row. But I really want us to be careful to use the word waste when we're talking about services for children, because fraud is intentional and it's criminal, right? And abuse is its own thing, but waste is a very broad term. And when you're talking about services that kids need, it can get into a really icky place of saying like, we're wasting money on this thing for this kid. And so I just want us to be mindful as we move forward, because it just tends to be flowing out of the mouth. And I want us to be mindful of that.
You know what? You reminded, we started off one meeting, and I said, thank you for reminding us about the why we exist in human services, right? So thank you for reminding us on that again. So you got some follow-up with us. Senator Gruenhagen, it's got like 20 minutes for the questions. So, okay, you're listening to the dialogue about what it is we're going to be doing next, and then it sounds like it. Senator Fateh, I know one of his questions, Ms. Grom, it looks like that was might have been asked and answered, but he's gonna follow up with that. But Senator Gruenhagen, go ahead.
Okay, thank you, Mr. Chair. Thanks for the presentation, Ms. Grom. I just did some quick research here, and right now, 1 in 36 children are diagnosed with autism. I looked back in 1960, it was between 2 and 4 out of 10,000. So it's really gone up dramatically. Do you have any thoughts on that or insight?
So the policy side, yeah. So the policy, maybe you want to do we have a clinical, with Dr. Larson running around here? We can start getting into the weeds on that. But the diagnosis stuff, Glenn, right next to you, Jim Abler probably knows that question. If you don't know at the top of your head, we will absolutely get the expert. That's to what Senator Gruenhagen's saying. Senator Fateh.
No, but also I think the testifiers were saying that specifically within the East African community, it's 1 in 16.
1 in 16.
In the Somali community, so, yes. In the Somali specific community, it's 1 in 16.
Senator Radke, on top of what Senator Gruenhagen asked.
Well, actually, not exactly on top of that. I'm kind of going back to some of the conversations we've been having, licensed versus non-licensed. They're all receiving payments from the department. Why is it such a big deal? You're the ones paying the bill, so you're still in full control, right? I mean, whether they need extra training or all of these things, I don't really see why the big deal in licensing. I mean, it's a program. I would think you'd have the same authority and same guidance no matter what.
Senator Abler.
What? Go ahead.
No. I thought you had something to add, because when you talked about licensing versus non-licensing, that's the debate that he started 12 years ago, Paul.
Well, I think we need some guardrails. I mean, I think everybody agrees to that, and that's one way. There's other ways to decide. I'm not sure licensing is for everybody's the answer either. So.
Yeah, and I guess what I'm after is, if they're receiving payment and the department is the payer, they've got the guardrails. A license doesn't make it one. They can operate with full control either way. I'm just throwing something out there. I hear so much about licensing. I don't know that that's the save all.
Yeah, you bring something, that was the same. Thank you. You bring that up. It's like, we always hear from the OIG can't do it because it's a non-licensed, right? At least that's a comment in the past, Jim. And I don't, is that debate worth shot again? And I know Senator Fateh wanted to say something.
Just briefly, Mr. Chair.
Yeah.
Sometimes licensing is a proxy for training, and where there's some oversight and on the ethics side, like I have a board, I'm licensed, and I can lose my license, and that doesn't necessarily guarantee that I'm good at what I do. But I think in this thing where things are kind of random, I think it has to be brought in some way. So I'm not trying to monopolize the discussion, Mr. Chair.
Ms. Crum, go ahead, and then we're going to go to Fateh.
Oh, sorry. Were you going to say something?
No, go ahead. I said, Ms. Crum, go ahead, and then we're going to go to Senator Fateh.
Mr. Chair, Senator Aki, to your question, I think we would agree that licensing is not a silver bullet. It doesn't fix everything, but it's a good start to help make sure that people have the training that they need, make sure that the supervision requirements are adequate. Just last year, we saw on the news horrifying footage of an individual worker, an EIDBI worker, repeatedly pushing and hitting a child. And that is the kind of thing that none of us want to see and that licensure can prevent. So that particular worker needed more supervision, needed more support. If DHS would have been able to be there on site, even in that case, DHS was not even able to respond to complete a maltreatment investigation. So this is, as I mentioned earlier, bigger than just fraud, although that is important. This is also about health and safety of children, children who really need our support.
And that's the purpose of why we get onto those services in the first place, to that point. Thank you. Senator Fateh.
No, yeah, thank you. Senators Aki, McQuaid, and Abler, I think, answered almost all of my questions, so I'll be very brief. I'm looking at page 10 of...
Good, the bad, and the Utki.
The good, the bad, and the Utki. Yeah, the good, the bad, and the Utki. So I see that on page 10 that there's approximately 12,000 providers, EIDBI providers. Do we know how many of those are like actively providing services versus like folks that might have just maybe applied and not doing anything or not getting any payments and things like that?
Ms. Grom.
Mr. Chair, Senator Fateh, yes, I can get you that after maybe the hearing. I don't have it memorized, but that 12,000 is individual providers, and I think there's about 220 or so
group
actual agencies, and then of those, about 100 of them are not actually providing services at all. So there's a large amount of provider agencies that are enrolled that aren't providing any services, haven't billed. So that's a question and a concern for us and something that we would like to address, and we'd be happy to work with you more on what those numbers are and why they might be that way.
So you're
I'm sorry, I didn't hear properly.
Yeah,
Sorry,
go ahead.
Did you, thank you, Mr. Chair, sorry.
Yeah, go ahead.
Did you say they're enrolled but not billing?
Yeah.
Yes.
Okay.
In 2024, there were about 220 provider agencies that provided services and billed, and roughly 100 additional provider agencies enrolled but not billing for services. So I correct myself. So it was 220 plus 100 enrolled, so about 320 enrolled, and 100 of those had not been billing in the past year.
Okay, and do you have any like understanding of maybe?
Senator Fateh.
Thank you, Mr. Chair. Are there barriers to providing those services? Were they just applying and then changing their mind, or do you know what was going on with those 100 folks?
Ms. Grom.
Mr. Chair, Senator Fateh, we aren't quite sure. I think we see this in other service lines as well in 245D, where there are a lot of providers that are enrolling, but they aren't actually providing the service. So there may be confusion about maybe they don't have what they need, the information that they need, maybe they don't have the clientele that they need, maybe they enrolled and they thought there was going to be more people to serve in their community, but turns out there's a different service line that's better for them, so really could be a multitude of reasons.
Do you know what Senator Fateh, what Ms. Osmond said to me? She said the 245D, as he's mentioned 245D,
Yeah.
how many, that issue that Ms. Grom just brought up, so maybe that's something to add to looking at this as well.
For sure.
Can I go to Senator Gruenhagen, or do you have a follow-up to do? Because we've went around the
good
turn, and we jumped over Senator, we went over Kazatki, and then it went back, and it never came back to Glenn. So, Glenn, does that answer your question from 20 minutes ago?
I'll research it. No, I'm used to being discriminated against, okay? So, I'd like to follow up with the questions I've got. I just repeat this. Right now, according to my research here just on the internet, 1 in 36 children in the country is being diagnosed with autism, okay? I know it was mentioned 1 in 16 Somalis, but back in 1960, it was between 2 and 4 children out of 10,000, okay? Something is desperately wrong and nefarious going on. I'm not sure what it is, but you can't go from 2 to 4 children out of 10,000 up to 1 out of every 36 children without something somewhere that needs to be double-checked. And I'm going to keep asking my questions because the thing is, last time I got interrupted, it took me about 20 minutes to get back to me again. No, but if you want to make, she'd like to make a comment, Ms. Chairman.
Ms. Osmond, do you want to comment to what Senator Gruenhagen is saying?
Yeah, research. Nobody is Minnesota, as much as it's on the radar when it comes to autism nationally, we are not focusing on causation. We are counting numbers, we are reporting the disparity there is, but we are not doing the causation, the scientific experiment that's required to conduct to find out why, what is there a genetic predisposition? What is it? Is it environment? We are not into causation. And guess what? In the federal government, there is so much money that's just for causation.
Yeah.
And Minnesota doesn't apply for that.
So, thank you, Ms. Osmond, for that. Senator, looks like Ms. Grom, did you? No, we're good. Senator Gruenhagen, go ahead.
Yeah. The thing that you take this 1 to 36 or 1 to 16 or whatever, and then you look at the graph that Senator Abler referenced, where back in 2016, it was about 7,500. 2017, it actually dropped to about 6,500. Average spending per EIDBI participant of the year. And then in 2018, it started to take off. And by the time you're up to 2023, it's 45,000 per participant, average spending. Now, you take the statistics of 1 in 36 or 1 in 16 or whatever, and you multiply it times the 45,000, and we're going to bankrupt ourselves, okay? Exactly. Plus, I think we're excluding people that could possibly use the service if we had a better average spending. So my question for Ms. Grom is, why do you think, or do you have a handle on why it has skyrocketed to 45,000 in 2023, and it's probably even higher now? I do not believe this is sustainable, okay? We want to help these children, but this is not sustainable unless there's very verifiable results for the additional spending, which I'm open to. But the thing is, you can't go from 2017 to 6,500 about to 45,000 and then increase the number of diagnoses for, and again, the causation to 1 to 36. I mean,
Is that when the benefits, Jim, wasn't the benefit set established 2016, 17, and went to effect 20? Those numbers in 2018 was the fact that we were never counting that. Is that correct? Do you remember that?
Well, I remember kind of. I'm just, maybe at some point, do you have an opinion, Ms. Grom, about why the increase in cost, just off the back of your head, or is there a reason you guys know already, or do you mind, can you comment on that?
Ms. Grom?
Mr. Chair, Senator Abler and Senator Gruenhagen, just to clarify, Senator Abler, you're asking about the increase in prevalence or the increase in spending?
Oh, the per capita
units?
spending, like quadrupling or more.
Senator Abler, I really don't know, and I would really warn against all of us dabbling. I think we should go back and find the information that we know, what data we have, continue to work with the community if we don't have enough. I think we would agree that we should be looking at that and understanding. It looked to me in the data that individual intervention services in particular were billing more units. I think we should take a look at it and better understand.
Mr. Chair.
Go ahead.
Oh, go ahead, you two.
Ms. Grom, I'm a fan. But just that answer is actually less than satisfying. Nursing homes would love to have that kind of increase. Hospitals would love that kind of increase. Going from 7,500 to 45,000 over a period of a decade has nothing to do with dabbling and causing harm to somebody. Somebody has found a way to run the billing meter. And I'd be interested to look at the ABA providers who have been doing this for a long time under CFSS and now moving into this and see what there is and just see what the correlation is by people that are, you know, semi-uncredentialed and those who are, and people that are generating complaints about, you know, young staff with cell phones, and see what they charge for a kid who's, for a young adult who's manning the store, what they charge for a day for that. And I just think that's, I mean, and the governor, I don't know why he decided that this is the reason for the deficit. And if he thinks this is an excessive amount of money, I think he should make you all go look at it, figure out where's the money. He may not realize that it's $7,500 to $45,000, but that's a massive increase. And we just had the whole New Way thing that we're worried about. Nobody should get rich on Medicaid. Nobody actually who's doing the work can get rich on Medicaid because the margins are too small or it's right at cost. And so to me, that's just and then we have people that are concerned that their particular community is going to be biased and not get services. Well, we're blowing through the money. And I think.
Am I able to make a comment, Chairman?
Thank you, Mr. Chair.
Ms. Hage, this is the committee, the committee is commenting. If I see your hand is up, my committee administrator can communicate with you, and then we'll get you making a comment. Actually, if Glenn, do you want to go first, and then we'll let her make that comment?
I'd be done by now if I wasn't there.
Hey, welcome to the committee. Glenn, I told you, didn't I not tell you this operates in any other committee you've ever been on? This is one that just, it goes around like this because people are having conversations.
Well, I have a suggestion, Mr. Chair.
Yeah.
We should find out well, you could use 2018 as a base, that we find out what services were provided and the average cost in 2018, and then what services are provided and the average cost in 2023. So we can have comparative data of what's really going on and driving this exponentially growing price. Yep. And whether what we're doing is actually effective would also be very important or helpful. So, Mr. Chair, I think you should request that, because this just cannot continue unless we get to the bottom of it, unless it's so effective compared to 2018 compared to 2023, and I can be convinced of that with incriminating data, but the way it looks right now, and then you add the amount of fraud that's being alleged in this program, it is disconcerting for Minnesota taxpayers and citizens, and we really need to get to the bottom of it.
So, thank you, Senator Grenade. It sounds like you're volunteering to commit to working with Senator Abler on this EIDBI, and that's perfect. There, thank you. That's exactly what it's about, and it's like if you have go ahead.
I got one more question.
I'm here.
Hey, I'm only asking a few. I got about 20 questions. I'm going to ask about 2 or 3, okay? The other thing is, there is technology available to help you find the fraud, is my understanding, okay? And I got that from some good references. So is there any technology being utilized in the department to help you identify fraudulent behavior in terms of receiving these payments?
Here's what we're going to do, Ms. Graham. This was a report. This was a combination. Glenn, I want us to side by that for the next, when we get the actual, when we get that in there. But to that, can you come back to us? Not you, but that's going to be clearly on the compliance side of it, where
Mr.
Senator
Chair.
Gruenhagen is going, unless you have a quick shot on that, but then I want to get on Lisa.
Yes, I'd be happy to return, or others would be happy to return and talk with you more, either here in committee or offline. We do use different kinds of monitoring technology. We have a proposal to do more of that. I would just say that we do have data about the cost in 2018 to today. It's in the report. It specifies which services are billed, are increasing in cost. And the report also specifies that some of the reason for the increase in cost is using different billing codes from when the service began in 2018. So we've got an increase in the rates. So that's what I mean, that this is a dense report, it's a complicated topic, and I think it'd behoove us all to look at the report in depth and definitely look into why there is that increase and all of the factors and what we know and what we don't know and make recommendations from there. We'd be happy to continue to work with you, Senator Gruenhagen.
Thank you for that reminder of this. Anissa, do you want to comment to Senator Gruenhagen, and then we're going to move on, you guys?
Yes, I'm so sorry. This is my first time testifying, and as a parent of 3 autistic children and being neurodivergent myself, I'm jumping every time something is mentioned, and I just want to give my lived experience perspective and also my knowledge. So I come from the country of Somalia. I was born there, and I came to the United States at 5 years old. And there's a misconception in my community that autism doesn't exist back home. And that is because back home, there's no diagnostic process for it. And 50, 60 years ago, or 45 years ago, that was also the case. We have advanced medically, and now we have tested, like we have assessments and therapies to address autism, and that's why there's a rise. There's even a rise in late diagnosed individuals with neurodivergency, whether it's ADHD or autism. In fact, I just read a report that said in the United States, there are 17 million adults who are diagnosed with ADHD. And so it's not a surprise to me about the numbers, the increase, because that's our reality. Neurodivergency is, I don't know that it's on the rise, but it's being diagnosed more. And then in terms of like the budget issues, and I'm not a senator, I'm just a parent. I have my 3 children, and they're always at the forefront of my mind. I'm also an advocate. And when I hear the discussions about budget and money being spent, that money being spent is being spent on my child in order to prevent them from being in a group home when they are an adult. I don't want my child in a group home. I want them to be thriving. I want them to be communicating. If my 7-year-old daughter could get therapies that will allow her to communicate, will allow her to regulate, will allow her to go to public school, as she's not able to right now because of her behaviors, I think that money is well worth spent, and I think that it will only save us millions and possibly billions of dollars down the line to invest in early intervention, despite what the cost is. And so I just wanted to make that comment.
I really appreciate the lived experience as a parent. Thank you, Ms. Mohammed, for, again, when we started 2 years ago, after when Senator Abler was chair for 6 years, it was about getting to this is our core, right? We're talking about human services. This is what it's about. And so you got to the why we do what we do. It's the why, and that's what I just want to keep us to focus on. There's Senator Fateh.
Oh, yes. Mr. Chair, I just got one quick.
I know, I'm going to come back to you, but he wanted to follow up on that. Senator Fateh. And then, Glenn, we need to move on.
Real quick, thank you, Mr. Chair. For one of the testifiers, I think it was Abdul Karim, can you reiterate or mention who are the major providers or the major entities that provide the services for these outside of the BIPOC providers?
Outside here I know several of them. There is Helping Hands. You want the EIDBI providers' names?
Yeah, you mentioned 2 big ones that you said. That
those are St. David and Anna Fraser. Yeah, those are the 2 big ones that had
behavioral dimensions. There are a lot.
They were the only 2 providers before we had this open to our community.
For sure.
And those are the ones that we were always in waiting line forever.
No worries, because I'm just having my opinion about why the prices skyrocketed. What I think was happening was we saw a massive increase in folks getting diagnosed. At the same time, 2 major players that probably had strong lobbying ties that can increase the amount of reimbursement at the same time. That had to have played a part in it, in my opinion. But now you've seen a large number of providers coming into the mix also, and that probably is leading to some of the issues that the other senators are mentioning. So, as to the question as to why we saw skyrocketing prices, that's what I'm thinking is happening here. If that made sense, Mr. Chair.
Mr. Fateh, thank you, Senator Fateh. Senator Gruenhagen, then we gotta move. We got.
Just real quick.
Yep.
I understand. I own an independent insurance company. I got families with autistic.
Wait a minute. You have an independent insurance company? Were you on the school board too?
Yeah, I know.
Go ahead.
No, I have families with autistic children. I know it's serious, okay? I want to help them just as much as anybody.
God bless
But what I'm trying to, I guess an example, when I went through grade school, which was a number of years ago, and through high school, I cannot remember in any class one child labeled and drugged for any reason, okay? And I could not remember through my entire K-12 education one autistic child.
Do you know
Not
why?
one.
Glenn, okay, I'm going to end it right there. You and I are going to have a conversation. We institutionalized kids back then. As a matter of fact, in Jim Abler's backyard, right, he rerouted those buildings to do things for homeless vets. But we still had 10,000 unmarked graves in the state of Minnesota. So let's you and I chat about that. I get you on that because it's like, where were those kiddos? Well, they were in state institutions, Glenn, and it was, so anyway, let's move on to.
I'm always open to additional information.
You're good. Are you kidding me? I'm glad you're here. I love this. So thank you, everybody. Christy, we're going to bypass obsolete rules because you actually live here, or at least in the cities. I want to thank everybody for coming forward. It sounds like Senator Abler is really going to take the lead on all this stuff, as he did 10 years, 12 years ago, whatever. And so I appreciate you, Christy, if you'd work with Senator Abler on especially on what the governor's proposal is. We want to make sure this committee is doing what we need to be doing. Senator Fateh, thank you. Is that okay, Christy, on the obsolete rules? We can come back another time on that. I appreciate that. Thank you, everybody. Thank you. Thank you. Thank you. Senator Fateh, you got Senate File 548. You got Jeff Nakbar and Rebecca Preston. You came in from, where'd you come in from? The West. Golden Valley. Not quite as far as Glencoe, but Golden Valley. It starts with a G, Glenn. They've got an A1 amendment, Senator Fateh. You want to go ahead and move that?
Yeah, I think it's just cleanup language. I'd like to move the A1 amendment.
Everybody got the A1 amendment in front of them. All those in favor say aye. Aye, opposed, same sign. Thank you very much, Senator Fateh. The bill is in the order that you want. You got Mr. Nakbar here and Rebecca Preston. So go ahead. The floor is yours.
Thank you so much, Mr. Chair, and I'll try to be quick. I'm here to present SF 548. This bill increases the maximum income standard for low-income elderly and disabled residents to receive medical assistance from 100% of the federal poverty guideline to 133%. Currently, that standard of 100% is the lowest of any category of people receiving medical assistance from the state. This low standard forces disabled Minnesotans to relinquish income they receive from Social Security disability income or other sources to receive the home and community care provided by Minnesota waiver programs. In bringing the income standard in line with other categories set by Minnesota law, SF 548 will end what is effectively a tax on disabled people seeking dignified medical care. We should not make people living with disabilities choose between health care and a livable income. Thank you, Mr. Chair, and with me today is both Jeff and Rebecca, and I'll pass it off to
me?
Ms. Rebecca. Thank you.
Okay.
Thank you, Senator Fateh. Jeff, who's going to go? Rebecca, Ms. Preston.
Ms. Preston.
Will you please, for the record, state your name and then the microphone's all yours.
Yes, my name is Rebecca Preston. Thank you, Mr. Chair and members of the committee. My name is Rebecca Preston.
Nice to meet you.
Yes, thank you twice. I live in the Dover Hill Apartments in Golden Valley. I have lived there for almost 8 years. I have a traumatic brain injury that I obtained in 2005 when the car I was driving was T-boned by a drunk driver. Today, I do not have a driver's license. I have severe cognitive disabilities, double vision, concentration issues, and a balance disorder. Because the highway between the two lobes of my brain was severed, I no longer play the piano, write short stories, read fiction, or knit. Those things were very important to me, and I couldn't believe that I couldn't live without them, but here I am. Medical assistance, also known as MA, has been and continues to be very important to me. It provides health care and services that allow me to live independently. I have had an independent living skills worker who has helped me and who helped and taught me how to interpret my mail and keep my house organized. She also brought me out into the community and taught me how to have fun. Since having a brain injury, I'm not very good yet at having leisure time. I also had an arms worker, adult rehabilitative mental health services. She would talk to me about how my week was and help me to be my own best advocate. I have graduated from those two programs and now have an in-home worker. That is a woman who picks me up and takes me out into the community to run errands and do my shopping. I also have a home health care worker who comes over and helps me clean my house. All of these things, which are provided by MA, have been very helpful to me. Without them, I would probably be living in a bed. Luckily for me, I have a 35-year work history before I was injured, and like many people, was paying Social Security taxes since my very first job. This allowed me to qualify for Social Security Disability Insurance, or SSDI, after becoming certified as disabled because of my injury. The problem is that my SSDI income, about $1,400 a month, plus puts me over the income limit in the elderly and disabled category for medical assistance. This is the only place where I can get those home and community services that I was telling you about. This brings me to the spend down, which for me means I have to pay $300 of that income back to the state each month in order to get my MA services. That does not leave a whole lot of money to live on. It still doesn't make any sense that because I am disabled now and for the rest of my life, that my income is so limited that it will barely pay my rent as well as my other bills. The MA income limit for people with brain injury and other disabilities desperately needs to be raised. Please support Senate File 548 so that I can keep more of my Social Security disability income to pay for my cost of living and get the services and supports I need to live independently in my community. Nobody really thinks much about what could happen to them if they become disabled in an instant, like what happened to me. I sure didn't. Nobody wants to need Social Security disability benefits. They've been paying for their whole working life. But if they do need these benefits, it would be nice if the state of Minnesota didn't take part of those benefits away to qualify for MA. It is just so unfair that people with disabilities are expected to live on such a low income. Such a low income just to get that health care and the home and community services they need. Thank you so much to Senator Fateh for authoring this bill, and I hope you will all support it and do anything you can to get it passed this year. Thank you, Mr. Chair, and members of the committee. Sorry. You're done. Oh, I'm done? Okay. Thank you for listening to me.
Yeah. This is the 133, the 100 to 133. We've been having this conversation, and Senator Utke, as we line up, do we have a fiscal? I'm going to ask what Senator Utke would be asking. Have you got a fiscal? Can I go ahead? Senator Utke, you want to ask that question?
Not yet. Mr. Chair, you could do it if you want, because that was going to be my first question. Have you seen the cost yet? Because I believe this is bill that's a rewrite from previous years, so you probably had a feeling for what the cost is and how many people would be served under this particular language in this bill?
Perfect. To that point, Jeff, I think Mr. Nakbar, that's not, you had the full one without asset limitation, so,
Yeah.
but Senator Radke, can you help us what do you think? Are you getting that? You looking at it? How much?
Thank you, Mr. Chairman. Jeff Nachbar from the Minnesota Brain Injury Alliance. And yeah, Senator Rickey, I think when you were a freshman, we started working on this together. We've seen many different fiscal notes over the years. We haven't got one strictly on this, but we're bringing this bill strictly on the income limit. We've seen different things with the asset standards. We've seen different things with rolling them back. We've seen different things with incremental changes over the years. So we don't have that yet, but my understanding is it's being prepared for just this one part of this issue.
All right. Senator Radke, follow up? Yes.
You know, just the next is, we know that the costs that we've been working with in the past, but how many, do you have, I guess there would be part of that fiscal note is the number of people that would be served by this additional change. Do you know what that is roughly? What are we looking at across the state?
Jeff?
Mr. Chair, Senator Rickey, the department has created many different fiscal notes with different sets of assumptions over the years, so they would be well suited, much more suited to answer that question specifically than I am. But it was both the sort of, we know it was a combination of both the increase of people like Rebecca, where we're taking $300 out of her pocket, as well as additional people that may qualify, and sort of different assumptions on how many more would come, depending on a whole, I think it was about 25 pages of assumptions.
Thank you, Senator Radke. Yeah, I don't think, it's like there's that section of it, and we've always looked at that, and I remember as years ago, we'd always been 133 to 100, 100 to 133, it's like that. So go ahead, Senator Abler.
Well, the good news is we got up to 100. And we did that together out of this committee. And whatever it costs, and I just distracted on the other topic, but whatever it costs, it comes out of the people that are like the poorest people. And so this is probably several hundred millions of dollars. Yep. But this money that comes out of those people least able to afford anything. And so maybe you already said that, but I'm sympathetic to it, and always a budget constraints, but this is one of the biggest injustices in the whole Medicaid system.
Totally.
Where they used to have to spend down to 75%.
Do you remember then we went to 75, 76, 80, 81? It was like battle, Jim.
And I don't know, this should have been fixed when the ACA was done. Should have been one of the costs of doing business, to treat people who were with a disability simply the same as someone who was low income. Anyway, speaking to the choir. Thanks, Mr. Chair.
I love it. Ditto's up here. Go find the money, Jeff, and we're good to go. We're going to lay this over, right, Jeff? And is there something you want to do?
Yeah, Mr. Chair, if I may, 60 seconds.
Did you just hear that? Yeah, no, we can. We got another bill to get through here, but you're good.
Thank you, Mr. Chair. I have about 60 minutes worth of comments on this bill that I'll save. But yes, Senator Abrams, and you guys are absolutely correct. We understand that this may not be the biggest category of people, but it's the most expensive group of folks, and it's also the folks that are held back the furthest and are being told, every year, sorry, we can't help you this year, maybe.
And this really gets me. When I see stuff like this, this is what we go back, and then it was to Senator Abler's point, the ACA, when they should have fixed this, right? And now when we are looking at $1.5 billion in possible service cuts to the most vulnerable people in the state of Minnesota, I'm up here now, Jeff, looking at you, and you've known me for 30 years, and I'm really not happy when I see this. This should have been something we took care of years ago, and now we're sitting here. We know it needs to be done. Yes, that is correct. It's the right thing to do. This gets to the why we do what we want to do. To Senator Radke's point, to Senator Abler's point, we're all doing that. So, Jeff, thank you for being here. Senator Abler, go ahead.
Well, Mr. Chair, we could send this to Finance, just to make them know that we care about this. What do you think? I think we might get unanimous support for that, and we could be making a statement, and it's a rocky road, but it's just a thought, Mr. Chair.
Is that a motion to move this to Finance as is? You don't have a fiscal note for this yet, but we know this is the right thing to do.
Mr. Chair, I'll move that the bill be recommended to pass and sent to Finance.
All right.
can do it. We have power, Mr. Chairman. It's up to you. I'll take your.
That's a legitimate recommendation to do that. Let's lay this over, pull it off the table. I think he wants to lay it over. What do you want to do? You want to go to finance with this, Fateh, or you want to just lay it over?
It's tempting.
It's tempting?
Lay it over.
You want to lay it over?
Yeah.
Senator Abel, you're okay with the chief other one?
Fine, I'll defer to we can just tell Mr. Chair who cares the most about this topic. I think that clearly, I'll withdraw my motion, Mr. Chair.
Let's tax Mr. Chair, let's tax the Chiropractors Association. Let them pay for it.
Oh my God, Senate file, this is funny. Thank you for, Senate file 548 will be laid over. Thank you very much, thank you.
Thank you, Mr. Chair.
Do you want to give me a hard time too? And
Sorry.
you almost had him, Jim.
Mr. Chair, it's just shocking. I moved to left with Senator Fateh on money. I'm afraid of that. That could have, you be careful about the image you get, Senator Fateh.
Senator Hoffman.
Chair Rasmussen, nice to see you. Mr.
Yes.
Chair and members, Senate File 476. There's an A1 amendment that just significantly tightens up and narrows the one-time grant program established in Section 9. I'd like to have that moved.
Senator Hoffman moves the A1 amendment as an author's amendment. Any discussion? Seeing none, all those in favor say aye.
Aye.
All those opposed say no. The A1 is adopted. Senator Hoffman, to your bill as amended.
Thank you, Mr. Chair and members. Many of us, we have the shared value in that increasing access to home care services that allows older Minnesotans and those with disabilities of complex health care needs to remain living in their homes. It's been something we've talked about for the longest time and continue to. Many of us, it's about three reasons. Number one, the access to home health services is most often the preferred choice of our constituents compared to care in a hospital, nursing home, or other long-term care settings. I remember a certain senator who said, home is what we mean and we mean it. I'm getting that quote wrong, but it was in one, do you remember that? That was the 1 year. So that's that one. Second one is access to home health services is a key step in easing the stress over the current overstressed hospitals. We're going to talk about decompression in this, Mr. Chair, and those congregate care facilities. Access to home health care saves our state significant amount of funding as compared to providing the care in an institutional setting. This is Minnesota Home Care Association is bringing it. They're going to be talking about the care evaluation visits and medical assistance. But with me is Kathy Messerly, who's the Home Care Association, and also Jennifer Baker from the Good Samaritan Society Home. We got about 5 minutes, so you guys will have to have a conversation. Mr. Chair?
Ms. Messerly, please introduce yourself to the committee and proceed with your testimony.
Thank you, Chair. Chair and members of the committee, my name is Kathy Messerly, and I'm the Executive Director for the Minnesota Home Care Association. Our members provide care in the homes to people that are older as well as individuals with disabilities. We're acutely aware of the growing number of Minnesotans who will have to turn to more intensive, expensive, and currently overly stressed facility-based care if they don't have access to home care. It's not the preferred option for most, and our state budget cannot support this intensive care for all, as the senator just stated. This bill contains 3 distinct proposals the legislature can advance. First, it establishes a reimbursement rate for a limited annual number of required home care evaluation visits. 3 specific kinds of evaluations. These specific kinds of evaluations are required. They're more comprehensive, and they take 3 to 5 times as long as a home care visit, which is how they are currently reimbursed. The 3 visits are the start of care, of recertification every 60 days, and a resumption of care when there has been an interruption in home care services. Section 8 of the bill adjusts the medical assistance reimbursement rate, bringing the rate somewhat closer to the cost of providing care. Included are skilled nursing, therapy, home health aid, home care nursing, and the homemaker services. With fewer people in the workforce, we must do all we can to offer appropriate wages and benefits to the individuals who do step forward to provide these critical services. And finally, the last section establishes a one-time grant program focused on recruiting new staff. The amendment, as mentioned, provides compensation to nurses who agree to serve as a preceptor for nursing students, the financial support to recognize these individuals for their additional commitment to exposing more nurses to home care services will be greatly appreciated. In closing, I want to thank the legislature for the significant investments you have made in home care over the years. In order to increase access, we must close the gap, as I've shared. We know legislators are faced with a challenging budget situation, but we look forward to partnering with you to advance thoughtful, economically sound approaches that are aimed at addressing the underfunding of home care. Thank you for your support of this bill, and I'll turn it over to Jen Baker, who is testifying in further support.
Thank you, Ms. Messerly. Ms. Baker, please introduce yourself to the committee and proceed with your testimony. Welcome.
Yes. Thank you, Mr. Chair and committee members, for allowing me to be here today. My name is Jen Baker. I am the administrator at the Good Samaritan Society Home Care. Thank you for the opportunity to testify today. The Good Samaritan is a nonprofit home care organization providing skilled nursing, physical, occupational therapy, speech therapies, along with home health aid services and other supportive services such as social work services. We see every day the incredible impact that access to home care services can have on the individuals and families that we serve. However, we also see how the underfunding of various home care services can impact Minnesotans who are in dire need of these services. For years, home care agencies have absorbed the high cost of starting and resuming care for a client in the home. An RN must do an in-depth evaluation visit, which can take up to 2 hours in the home alone, as well as another 2 to 3 hours of documentation after that visit. This is done to comply with state and federal standards of care, and we're reimbursed for those visits no differently than a regular routine home follow-up visit that may take only about an hour of time, including documentation and the visit itself. It's very challenging to make this service work when money is lost on these in-depth evaluation visits. The proposal in this bill to allow for separate care evaluation reimbursements would be an extremely helpful step forward in addressing this underfunding of service cost. Additionally, while our organization works to have as robust wages and benefits as possible for our incredibly valuable staff, at the end of the day, we are limited by the legislatively set medical assistance reimbursement rates that we receive. The individuals that show up for work day in and day out in home care and caregiving roles are truly some of the most valuable workers in our state, and their payment rates should better reflect that reality. Our agency in 2024 alone had 325 potential medical assistance referrals in which we had to turn away because we could not provide home health services due to staffing and reimbursement limitations. And I believe that there are a lot of other Minnesotans out there that currently are unable to access care. Lastly, we've seen the positive impact that comes when we're able to have a nursing student come for a clinical rotation within home care. Individuals who hadn't considered going into this line of work or didn't know much about it are exposed to how meaningful and educational it can be. However, the current workload of our nursing staff makes it a challenge for them to take on the student preceptor role, and it would be helpful to offer some kind of compensation to recognize those who step on and take this on. So I ask for your support of this proposal to help more Minnesotans across the state get access to the supports that they need to remain living in their own homes. And I again thank you for your time, and I'm happy to help answer any questions.
Thank you, Ms. Baker. Question from Senator Abler.
Thank you, Mr. Chair and Mr. Chair. You know, if you wanted to, like, you know, in Washington, they have these titles for bills. This would be the pay now or pay later bill. And, you know, Senator Hoffman and to the members of this committee that have been veterans, we have struggled in this committee to find every way we can to push more money into this sector. Yep. And, you know, there's no news here today. Maybe this will make the news. Oh, we're trying to solve this problem. But it's one of the most important core functions we have. And you don't know that you need it until you can't find it. There's a number of home care agencies that don't serve Medicaid clients because their rates are so lousy. There are people that would love to do home care, but they can't afford it. And we're much more willing as just the way the government goes to pay for someone to care their way out of home care because they have to find somebody and go into assisted living or an elderly waiver program or a nursing home, which costs more. And so, Senator Hoffman, we were just chatting. I don't know why on earth, hey, fiscal people up there, dynamic scoring. We buy this, you don't gotta buy that, okay? Anyway, so in a time when budgets are short, we have to pay for this, Mr. Chair, if we do, if we find the money.
Yeah.
To save, we're gonna spend $10 million on this to save 20, but we gotta spend the 10.
Yep.
And the 20, you know where it's gonna go, Mr. Chair?
General fund.
Roads
Yeah.
and tax cuts. And anyway.
Sorry, Mr.
So this
Chair,
is just really important. So thanks for being here again. We gotta just keep beating this drum because this is really important. And somehow, someday, they're gonna actually take in consideration the next iteration past just spending the money to what it will save. Anyway, I've given that speech 10 times, Mr. Chair. Thank you.
Any further member discussion or questions? Senator Gruenhagen.
Yeah, thank you, Mr. Chair. Yeah, I do have a dynamic versus static bill in. We should use dynamic scoring. That would alleviate a lot of so-called excess spending. And you'd actually come, the difference between dynamic and static is static, I heard it explained one time, you're approximately wrong, or you're precisely wrong. With dynamic, you're approximately right. So we go with fiscal notes that are precisely wrong versus dynamic, which is approximately right.
Love that.
Any further member discussion?
I want that on a T-shirt.
Seeing none, Senator Hoffman, do you have any?
Mr. Chair, thank you. To that point, that dynamic versus thing that Senator Abler brought, I appreciate. But Mr. Chair, thank you. And I think if we could lay this over to have further discussion.
Thank you, Senator Hoffman. Senate File 476 is laid over for possible inclusion in the omnibus bill. And with no further business, we're adjourned.
Thank you.